Welcome to the deep dive. Today we're looking at a pretty wild paradox in aesthetic medicine.
Yeah, it's a fascinating one.
Right. It's this idea that you could spend thousands of dollars on a premium injectable and then immediately follow it up with a state-of-the-art skin tightening device.
And completely ruin it.
Exactly. You might literally melt your investment away. So we're digging into a big stack of clinical studies, medical blogs, and dermatological reviews focused on the biomechanics of intimate wellness.
Specifically, female intimate wellness, which is a rapidly growing field.
Yes, and our mission today is to analyze what actually happens at a cellular level when you combine two immensely popular treatments. So it's the G-shot along with radiofrequency or RF tightening.
Right.
And whether you're a practitioner who designs treatment protocols or maybe you're just someone researching the science behind tissue rejuvenation for yourself, this dive is going to completely shift your perspective on how energy-based devices interact with, polymers inside the human body.
What's fascinating here is that the clinical trend often outpaces the biochemical research. Like, we see this huge rush to stack therapies.
Because people want results faster.
Exactly. The assumption is that combining a volume-adding treatment with a heat-generating device is going to yield these compounded superior results. But without a really precise understanding of the molecular chemistry and, honestly, the laws of thermodynamics,
Exodynamics, yeah.
injecting a hyaluronic acid filler and immediately applying deep tissue heat is essentially like commissioning an intricate, delicate ice sculpture
Oh, I like this analogy.
and then setting a high-powered space heater right next to it.
Right, it's just going to turn into a puddle.
Yeah,
Which means we really need to understand the individual components before we smash them together.
definitely. We have to look at the why first.
So let's look at the clinical context driving the demand for these treatments in the first place. The sources detail the underlying etiology of vaginal dryness and tissue laxity, and it goes far beyond the standard narrative of just estrogen depletion during perimenopause.
Oh, way beyond. The clinical blogs in our stack outline a really complex web of at least 7 primary causes.
Wow, 7.
Yeah. I mean, yes, estrogen withdrawal is a massive driver, right? Because it dictates the thickness and the elasticity of the vaginal mucosa. But we're also looking at the localized tissue impacts of things like pelvic radiation.
And systemic chemotherapy, right.
Exactly. And we also see severe dryness driven by autoimmune conditions, like Sjögren's syndrome is a big one.
Sjögren's, right, because that systematically attacks the body's moisture-producing glands.
Right. It just shuts that production down.
And the pharmaceutical factors really stood out in the literature as well. Like, the sources point to everyday medications. We're talking SSRIs for depression, antihistamines, hormonal contraceptives.
Which so many people are on.
Right, and they have a profound drying effect on mucosal tissues. And then there's the impact of elevated cortisol.
The stress.
Yeah, chronic stress.
Okay.
It actively suppresses the parasympathetic nervous system, which, that's directly responsible for natural lubrication of tissue engorgement.
So when you aggregate all those factors, you've got a vast demographic dealing with genuine physical discomfort, structural laxity, and a significant drop in their female sexual function index, or the FSFI.
Which is how they measure this clinically.
Exactly. And for decades, the standard of care was really limited to topical interventions.
Like creams and lubricants.
Right, or systemic hormone therapies. But systemic hormones are often strictly contraindicated for patients who have, say, a history of hormone receptor-positive cancers.
I just can't take them.
They absolutely can't. So this therapeutic gap is what popularized anterior vaginal wall augmentation.
Which is clinically dubbed the G-shot.
Right.
And based on the procedural data, what they're doing is taking cross-linked hyaluronic acid HA and injecting it directly into the submucosal layer of the vaginal wall. The sources even give the exact standard anatomical coordinates.
Right. It's 2.5 centimeters posterior and 2 centimeters lateral to the mid-urethra.
Okay, let's unpack this for a second because I have to push back on the premise here. If the contemporary anatomical consensus in our own sources explicitly states that the G-spot doesn't actually exist as a distinct, isolated organ,
right,
how can we claim this injection is targeting anything at all? I mean, aren't practitioners essentially just blindly injecting filler into a generalized area and just hoping for a result?
That is the core of the anatomical controversy. And the distinction is really crucial. You will not find a discrete capsulated G-spot organ under a microscope. It's not there.
Right, it's not a magic button you just press.
Exactly. Modern histology defines this region as the clitor-ithrovaginal complex. It's a highly integrated functional network where the anterior vaginal wall closely intersects with the periurethral tissue and the internal crura of the clitoris.
Okay.
So the HA injection isn't attempting to enlarge some mythical isolated button.
It's more about altering the physical architecture of that entire space.
Yes, exactly. It's purely mechanical. By placing a hydrophilic or, water-attracting HA bolus in that specific submucosal coordinate, you are mechanically thickening the urethrovaginal space.
Oh, I see.
And that added volume increases the physical friction and tissue apposition during intimacy, which subsequently amplifies the stimulation of the rich nerve plexuses distributed throughout that whole complex.
And the data supporting that mechanical intervention is actually pretty striking. I mean, we have a prospective pilot study comparing this HA augmentation to platelet-rich plasma, or PRP.
And the results were significant.
Very. The HA cohort demonstrated a 68.1% improvement in their FSFI scores at the 3-month mark. And that was specifically isolated to the arousal and orgasm domains.
Compared to the PRP cohort, which...
And you only showed a 45.7% improvement.
Right, because the HA delivers immediate structural support. It acts like an architectural scaffolding. But, and this is the kicker, while filler provides instant volume and hydration, it does not alter the underlying cellular health or elasticity of the native tissue over the long term.
It's just scaffolding.
Exactly, it's temporary.
Which brings us to the second half of this clinical equation. If HA is the temporary scaffolding, practitioners are utilizing energy-based devices to actually rebuild the biological foundation.
The RF devices.
Right, so let's examine the mechanism of transvaginal radiofrequency.
The transition from injectables to energy devices requires a real shift in how we think about tissue manipulation. Devices like Sectum or Empower RF, they don't rely on ablation.
They aren't burning or cutting the surface.
No, not at all. They utilize bipolar or monopolar configurations to pass a high-frequency alternating electric current into the mucosa.
And the key mechanism detailed in the dermatological reviews here is tissue impedance. So the device isn't just like radiating heat into the body like a heat lamp would.
Right, it's totally different.
The electrical current meets resistance as it travels through the density of the mucosal and submucosal layers. And that biological resistance to the current is what actually generates the thermal energy from within the tissue itself.
And the temperature gradients here are really critical to understand. The surface of the mucosa is typically maintained at a controlled, tolerable level, usually around 38 to 42 degrees Celsius.
Which feels warm but not painful.
Exactly. But in the deeper dermal layers, that thermal energy can reach up to 70 degrees Celsius.
Wait, 70 degrees Celsius. We are talking about subjecting internal tissue to intense heat. How does that localized trauma actually translate into structural rejuvenation without just, causing a severe internal burn?
It comes down to thermal relaxation times and the basic biology of the wound healing cascade. At those specific temperatures, the triple helix structure of existing lax collagen fibers instantly contracts.
Like shrinking.
Right. But more importantly, this controlled thermal trauma triggers a massive microinflammatory response. The body detects the heat stress and signals localized fibroblasts to rapidly synthesize new collagen and elastin fibers.
It's essentially tricking the body into healing itself.
Exactly.
And the histological evidence in the sources illustrates this perfectly. There's this one study utilizing a multiparous swine vaginal model.
And they specifically choose that model because swine tissue that has undergone multiple childbirths closely mimics human postpartum vaginal laxity.
Right. So after exposure to this transvaginal RF, the tissue biopsies revealed a 52.8% increase in elastin and a staggering 103.6% increase in collagen concentration.
And that extended up to 1.3 millimeters deep into the tissue.
Wow.
Yeah, so you're fundamentally reversing the structural degradation caused by aging or estrogen withdrawal. You are increasing the tensile strength and the elasticity of the vaginal wall at a cellular level.
It makes me think of baking bread.
Okay, baking bread, I like that.
Right, like you apply the right amount of heat and the dough rises and firms up, it gets structural integrity. But if you turn the oven up way too high or bake it too long, you just burn the house down.
That is a perfect analogy, and it brings us directly to the central conflict of our deep dive today.
Because the clinical logic seems sound on paper.
Right. Right. A patient wants the immediate mechanical volume of the HA filler, and they want the long-term collagen synthesis of the RF treatment. So why not perform both in a single session for maximum efficiency?
Right. Save time, get both results today. But the research indicates that doing exactly that is how you actively destroy the filler.
It's a disaster.
So how does combining radiofrequency anterior wall tightening with a G-shot actually alter the filler's molecular stability?
Well, we have to look at the polymer chemistry of hyaluronic acid. HA is a polysaccharide, which means it's a long, complex chain of carbohydrate molecules.
Right.
Polysaccharides possess highly specific thermal degradation thresholds. When you introduce the intense, deep dermal heat of an RF device.
Because we said it was up to 70 degrees Celsius internally.
Right, exactly.
Hmm.
When you introduce that heat directly adjacent to a fresh HA bolus, the thermal stress just violently fractures those molecular chains.
It breaks them apart. And the sources describe this as a rapid loss of viscosity. The gel structure basically collapses under the heat, losing its ability to hold water or provide any mechanical support.
Yeah, it melts.
Here's where it gets really interesting, though. It isn't just the physical melting of the polymer, is it? The heat is also triggering a biological response against the filler.
Oh, yeah. The thermal degradation is a two-front war. First, you have the physical fracturing of the polysaccharide chains. But second, the localized heat and the resulting microinflammation act as a distress signal to the body's immune system.
Oh, wow.
Yeah, this thermal trauma triggers the rapid release of endogenous hyaluronidase.
And that's the body's naturally occurring enzyme, right?
Right, and its sole physiological purpose is to cleave and dissolve hyaluronic acid.
So by applying the RF wand over the freshly injected site, the practitioner is not only physically melting the polymer chains, they're actually weaponizing the patient's own enzymatic defense system to aggressively flush out the filler.
It's a double whammy. And the clinical evidence of this collision is heavily documented. There's a clinico-histological analysis by Gerard Tanaporn and colleagues.
Let's talk about that one, yeah.
They designed a study specifically to observe this simultaneous interaction. They injected an HA filler and then immediately applied monopolar RF at 42 degrees Celsius to the surface tissue.
And what they found was crazy. The volumetric analysis showed a 36% reduction in HA filler levels immediately following this simultaneous treatment.
Immediately.
That's over a third of the product.
No.
Essentially a third of the patient's financial investment just eradicated before they even leave the clinic.
Yeah, the histology showed the entire matrix of the filler collapsing. The architectural scaffolding is completely undermined by the thermal intervention.
But the Girard-Tanaporn study provides a really crucial secondary finding too, regarding thermodynamics and tissue integration.
Right, the weight strategy.
Exactly. They discovered that altering the timing of the treatments fundamentally changes the survival rate of the HA polymer. When the researchers delayed the RF application by 14 to 28 days following the initial HA injection,
The filler degradation plummeted.
it plummeted from that massive 36% down to merely 7%.
It's a huge difference.
So what biological mechanism is protecting those polysaccharide chains after a 2-week delay?
The protection comes from neocollagenesis and tissue integration. During those intervening weeks, the acute inflammation from the initial needle trauma subsides. And simultaneously, the body recognizes the presence of the HA bolus and begins weaving a protective, microscopic web of collagen fibers around and through the filler matrix.
So the filler basically becomes anchored within the native tissue.
Exactly. It becomes a unified structure. And once that collagen capsule is established, it acts as a physical and thermal buffer. It shields those delicate HA chains from the acute heat spikes of the RF energy.
And because the tissue has stabilized, the RF application doesn't trigger the same aggressive, localized release of the endogenous hyaluronidase.
Right, the body's alarm bells aren't ringing in the same way.
So logically, the standard clinical protocol dictates spacing the treatments out by a month. But patient behavior and clinical economics, they demand efficiency.
Nobody wants to come back a month later if they don't have to.
Oh. Right. Patients are seeking a single appointment, a single recovery period, and immediate synergistic results. If the barrier to simultaneous treatment is thermal degradation, how are practitioners bypassing this without destroying the results?
This is where it gets really clever. The workaround doesn't involve changing the energy device. It requires changing the foundational polymer chemistry of the injectable itself.
Okay, so a different kind of filler.
Specifically, we have to examine the cross-linking agents used to bind the hyaluronic acid molecules together. Natural HA metabolizes in the body incredibly rapidly.
Right, in a matter of days.
Exactly. So to formulate a dermal filler that persists for several months, chemical agents are introduced to link the individual HA strands together into a stable gel. Now, the vast majority of standard HA fillers utilize a cross-linking agent called BDDE.
And BDDE is the specific crosslinker that proves highly vulnerable to the thermal degradation we were just talking about.
Yes. The bonds it creates are relatively rigid, and they fracture easily under high temperatures. So to achieve same-day synergy, clinical protocols are shifting toward a newer generation of fillers that utilize a completely different cross-linking technology called PEG.
Which stands for polyethylene glycol diglycidyl ether.
Exactly.
So let's explore the mechanical differences of PEG. Why does swapping this one specific chemical agent suddenly render the filler heat resistant?
Because it fundamentally alters the architecture of the filler matrix through a process called pegylation. Instead of creating simple, rigid links between the HA chains, PEG-E constructs a highly complex, three-dimensional molecular scaffold.
Okay, a 3D scaffold.
Yeah, and this scaffold operates almost like a dense, microscopic spring system.
And the sources indicate that pegylation transfers unique properties to the filler, specifically making it highly hydrophilic, but more importantly, rendering it non-immunogenic.
And that non-immunogenic property is the absolute critical factor for thermal stability. Because the 3D PEG-E scaffold is effectively cloaked from the body's immune sensors, introducing deep tissue heat via RF does not trigger the massive inflammatory cascade.
Oh.
Right. The body doesn't recognize the heated PEG-D filler as damaged material, so it doesn't deploy the endogenous hyaluronidase enzyme to dissolve it. The 3D scaffold itself acts as an internal thermal buffer, protecting the structural integrity of the HA chains.
And we have compelling real-world evidence of this chemical workaround in our sources.
Yeah.
Dr. Elmadali published a case series focusing on this exact same-day synergistic protocol.
And this was specifically treating severe vaginal atrophy in cancer survivors.
Which is an incredibly important application given that's a demographic in desperate need of non-hormonal interventions.
Absolutely. The protocol was highly targeted. They injected the thermally resistant PEG-D hide directly into the labia majora to restore mechanical volume, and then during that exact same clinical session, they immediately applied bipolar RF.
The parameters were really specific, too. They used continuous circular movements on the vulva at 5 to 10 watts, followed by intravaginal application at a higher energy output, like 15 to 20 watts in pulse mode.
Right. And because they utilized the PEG-2 cross-linked filler, that massive 36% degradation observed with standard BDDE fillers, it simply did not occur.
The scaffolding held up.
The architectural scaffolding held firm against the localized heat. The clinical outcome was a dramatic, compounded improvement across all domains of the female sexual function index.
So they achieved the ultimate clinical goal, the immediate structural support and hydration of the HA filler, working simultaneously with the long-term fibroblast activation and collagen synthesis driven by the RF device.
Exactly. It proves that stacking therapies is entirely viable, provided the practitioner has a really deep understanding of the polymer chemistry involved.
So to synthesize the core findings of this deep dive for you listening, combining anterior vaginal wall augmentation with radiofrequency tissue tightening offers a highly effective, synergistic approach to intimate wellness.
But you are navigating complex thermodynamic thresholds.
Right. If a standard BDDE filler is utilized, clinical evidence mandates separated the treatments by 14 to 28 days to allow for that tissue integration and thermal protection. Attempting simultaneous treatment will just actively degrade the polymer and weaponize the body's own enzymes against the filler.
But leveraging PEG-D cross-linked fillers introduces a 3D molecular shield, and that bypasses those thermal limitations, allowing for safe, same-day compounded tissue rejuvenation.
It really highlights a crucial evolution in aesthetic medicine. Like, we're moving past simply treating anatomy and entering an era where practitioners must deeply understand material science and thermal conductivity.
It's bioengineering, really.
Which brings us to a final, rather sobering piece of data from the sources that we want to leave you to analyze.
Yeah, this one is pretty wild.
We spent this entire dive examining how energy-based devices can negatively impact injectables. But there is a study by Yi and colleagues that flips that dynamic entirely.
Right, exploring how the injection process itself can catastrophically alter the safety profile of an energy device.
Right, so the study investigated the combination of injectable fillers and lasers, which is another prominent category of energy devices. And they identified a severe thermal hazard stemming from one of the most common, seemingly benign side effects of literally any needle injection.
Subcutaneous bleeding.
Right. A little bruise.
Yeah, if the needle nicks a microvessel during the submucosal injection, it leaves a small, localized pooling of blood beneath the tissue surface.
And normally we barely register it. But you et al. Found that hemoglobin acts as a highly efficient chromophore.
Meaning it absorbs specific wavelengths of laser energy incredibly rapidly.
So if a practitioner injects the filler, it inadvertently causes a minor subcutaneous bleed and then subsequently runs a laser device over that exact coordinate.
The pooled blood acts as a thermal sponge.
Wow.
Yeah, it violently absorbs the laser energy, hyper-concentrating all that heat into that single localized pocket.
Which can result in severe internal tissue burns.
Yeah. It is a stark reminder of the complexity of the human biological environment. A practitioner is never operating on a static canvas.
No.
Every single intervention interacts dynamically with blood flow, enzymatic responses, and material thermal thresholds in real time.
It just completely reframes the concept of protocol stacking. It isn't merely a checklist of synergistic procedures. It requires a deep, uncompromising respect for the biochemical chain reactions occurring just beneath the surface.
Couldn't agree more.
Well, thank you for joining us on this deep dive. Keep questioning the mechanisms behind the protocols and stay intensely curious about the science driving clinical innovation.